I'm going to just talk very, very briefly. I'm just kind of part of the introduction team about this concept of the complete digital eye exam for all newborns. And I believe it does make sense. Many of us went into ophthalmology because we were told it's the window to the soul. And I really believe that that's true. We can learn so much from examining the eye, not only just find pathology, but discover things about the infants that the pediatrician neonatology group needs to know. So the RetCam imaging system, why it makes sense is what we want to discuss today. I have not done universal screening myself, but we're setting up a system to do that in Houston, Texas, and the people on the panel have various degrees of expertise in this and are going to impart really their true experience in it. Of the 5 human senses, interestingly, almost 83% or more of our input into our brains comes from sight. So this is really important that we diagnose and maintain as much as possible any functioning vision that we can. And we all know that. That's why we're in pediatric ophthalmologists, those of us who are. It's very interesting that there is a great deal of neonatal screening that goes on. And when you compare it to the other things which are very commonly screened for, phenylketonuria, hemoglobinopathies, hypothyroidism, cystic fibrosis, and hearing loss, in decreasing order, but with some frequency, these are all very important and frequent, and they are, in our country, mandated by law. So it's interesting, there's a 0 left off here, this should be 70. The newborn eye examination screening is not something that's mandated. I mean, they ask them to look for a red reflex. Many of them don't, as you well know. I've had children referred to me that have no eyes at all, where the form says term birth living child with a good red reflex, and you know they haven't looked at all. So this is an effort to make that kind of thing go away and really get some digital data on eyes. So newborn eye disease, excluding refractive errors, is 1 in 70. Excuse that, that's a typo. And the newborn eye disease, excluding retinal hemorrhages, is 1 in 7. So this is something that's an important thing to screen, much more common than anything else that you're going to find that we are mandated to screen for. Photographic documentation, all of those of you who use RetCam, and I've used it for more than a decade, realize that it delivers an objective, interpretable, detailed set of images for you. It allows you to compare images over time. It enables you to do remote consultations, or consultations in this case with another field, such as neonatologists and pediatricians. It serves as an effective educational tool for staff, for parents, and provides reliable, defensible medical legal documentation when necessary. In addition, it also allows us to intervene and do something for these children. Now, I give a long, and can give a 1, 2, 3, 4 hour lecture on embryonic problems that occur in the newborn, depending on the tissue that's affected and how you can trace it back and what other things are associated. And so this is one of my passions. I love ROP and I love ophthalmic genetics. And this is an offshoot of, for me, of ophthalmic genetics because at least half of the genetic syndromes have some kind of eye findings. And the eye is embryologically made up of everything but endoderm, everything but the GI tract, everything but the gut. So you'll find syndromes that have neuroectoderm involved, surface ectoderm involved, mesoderm, neural crest. It's a very complex thing, and you can go on for hours. Embryologically, I usually divide it into about 6 different sections where you talk about early development, which are the major neurological impairments where you don't form the eyes correctly and you have major malformations. Then I talk about lens or surface ectoderm, which is just pinches off of the skin. And then the retina, which is the neuroectoderm alone. And then the vascular components of the eye, such as the what's involved in retinopathy of prematurity and in the anterior vascularization on the surface of the iris. And then also the lids, which is surface ectoderm, and then there's this big cornea anterior segment in which they all get together. So to make it a simple thing for students, I always say everything is one layer. You know, the early development is one layer, the lens and lids is one layer, vascular system is one layer, retina is one layer, and only the anterior segment do they all come together and make a big group of syndromes that you can really study well. But just to show you the kind of things that I would hope that we might be able to glean from using universal eye screening. Let's take just one example, the lens, which is from surface ectoderm. Congenital cataracts, the most common things we see in the lens, they're from surface ectoderm, usually bilateral and symmetrical, usually nuclear rather than cortical, and they need to be diagnosed very early to prevent bilateral deprivation, amblyopia, or in the case of unilateral cases, those are important too, to be aggressive with them, because you have a very limited window where you can identify them, treat them, get them optically corrected, and avoid legal or even worse blindness. So this is one of the really primary things that we would hope to get diagnosed early by this system. And I divide the etiologies into familial, where there's no other systemic involvement, such as usually autosomal dominant families, metabolic, usually autosomal recessive disorders that do involve other systems in the body, and then infection, congenital of all kinds. So this is an example of an autosomal dominant bilateral case of cataracts, which would be like our primary thing to find by this system. And you would be surprised at how many bilateral cataracts get by the nursery and even by the pediatrician on their first exams. Maybe you wouldn't be surprised. Maybe you've seen them come in at 2 and 3 months with nystagmus too. And that's late. That's too late. We often see metabolic disorders with, for example, this is the classical galactosemia oil drop cataract. Nothing else looks exactly like this. And of course, there are many systemic features to this disease, and you're able, by restricting galactose in the diet, to make this person a normal person without any further progression, in fact, regression of this cataract, and without any mental retardation and liver and so forth problems. So this diagnosis made early is very important. And then here's the infection I like to present, and that's rubella. This also is a very classical appearance to a cataract. It's a nucleus in a bag of water, because if you turn the baby's head, the nucleus will move from one side to the other side, and there's nothing really that looks like a rubella cataract. So that really is a basic introduction of the way I like to look at these systems in the eye and the way I like to think about genetics and the eye. The RetCam provides a whole array of lenses that can be used for external imaging, The face is very important. A profile to show micrognathia or abnormalities of the ear is very, very important. Also, you can find other body parts, for example, Rieger syndrome with an abnormal umbilicus or something like that, and capture those with the external lens. And then other external views, including the ocular adnexa, any trauma like from a forceps, and any positions of gaze that seem not to be right. And then you can also record anomalies of the lids and lashes, such as colobomas or inturning lids, and of the iris and conjunctiva, and ultimately the red reflex, which I really try to stress as an important part of an examination to all students, medical students that come through. We get a lot of medical students coming through who are going to be pediatricians, and I really like to stress this red reflex thing. And this is very important for them to learn how to look for this. They also provide a very wide angle on the other end of the spectrum for retinal imaging. The 130-degree lens, which gives you a wide degree of imaging. It's a small tip with good illumination, and it's good for term as well as preterm infants. Most of us are used to using the RetCam for ROP, but you can use it very well in term infants, and some of the other doctors are going to talk about this. Then they have another set of lenses that are larger magnification. The 80-degree lens, I think, is especially useful for anterior chamber and angle imaging, and gives you a really good view of children that you suspect of having anterior segment dysgenesis or who have glaucoma that's frank, or any of those kind of syndromes that you want to see the angle. And then lastly, they have a really large central retinal imaging lens, the 30-degree lens, which you can focus in on the macula, the optic disc, and any special lesions that you see in there. I actually have seen in screening ROP a very teeny retinoblastoma in the macula. And I mean, that would be a perfect lens to do that. And I think that's probably one of the earliest retinoblastomas I've ever seen diagnosed, because I think it was just about 34, 35 weeks when we noticed it. So this is the kind of thing that you can do and record, and there are an array of lenses that are available, and the kind of thing that we want to encourage people to look for. Now, I know that it's not something that the ophthalmologist maybe wants to do, but certainly technicians can be trained to do this, and it can increase your referral. You're going to get these patients anyway, but wouldn't it be nice to get them early enough to do something for them? That would really be nice. So with that, I'm going to stop and turn this on to other people who've had more experience in doing this than actually I have. Thank you.